Hey, hello everybody, and thanks for joining us for another edition of the Worcester District Medical Society's cable access information show called Health Matters. I'm your host, Dr. Michael Hirsh, and today we're going to have a really informative session with a very, very bright, high-risk obstetrician named Dr. Julianne Lauring. So welcome.
Thank you. Thank you so much for having me.
Oh, this is going to be terrific because, as you all know in the audience, we are in the midst of the pandemic, 1 year into it now, and we're coming out of the tunnel, starting to see the light at the end of the tunnel with vaccinations going on, and the hope that we can get to some kind of normal maybe by the end of the summer, maybe. But a big part of the questions that I certainly get in my role as the Department of Public Health Medical Director and Information Officer is what about pregnancy? Pregnancy and COVID, vaccination and COVID in pregnancy, all of these issues floating around, and I'm so glad you're here to clarify.
Thank you. Yeah, we have been looking for answers and waiting for information and been sharing with patients and our families as well. This is a very common topic we hear about.
Right. So very basically, can you tell us a little bit about what the virus, coronavirus, COVID, whatever you want to call it, does to a pregnant woman that might be different than a regular healthy woman who's not pregnant, or to anyone else, and also how it might affect the unborn child or the child once born?
Yeah, that's a great question. So to start with, pregnancy is a time where the body is working really hard, right? Supporting that other person. So people who are pregnant don't have a lot of extra capacity to be sick. And so when pregnant women get respiratory illnesses like COVID, some of them don't have the ability to tolerate that extra disease. So thankfully, the vast majority of pregnant women who have COVID have either no symptoms or very mild symptoms, but there is a small proportion who will become incredibly ill. And we know that pregnant women are more likely to need help with ventilation. They are more likely to need breathing tubes, more likely to need intensive care, and are in fact more likely to die than their non-pregnant cohorts because they just can't support that extra respiratory need that the virus causes in women.
Yeah, well, for the folks at home, you can imagine that if you have a very healthy baby inside of your womb and it's pushing up on your diaphragms, you already have what we would call diminished reserve in terms of being able to take a deep breath, and we know that baseline pregnant moms have a higher ventilatory rate, and that's one of the things that COVID causes is higher ventilatory rates. So there's only so high you can go before you go over the cliff, right?
Right, exactly. And women, they need that extra oxygen. They're pulling in extra oxygen, and it's going to the baby. So COVID in particular drops your oxygen levels, and so that you're really, really low because now you're not only feeding that baby who's taking it before you get it, but your oxygen is not enough to support your own health anymore.
So have you had any patients that have had dire outcomes from this?
We've been relatively lucky. We did have several women need intensive care, need intubation. We had one woman get delivered very prematurely because we felt that was our only option to try to improve her health and the baby's health. But we haven't had anyone so far pass away. Everyone has eventually met their baby, but one woman, it was weeks before she got to meet her child.
Wow. It's such a dramatic time in people's lives, and I think it's not just the moms but also the dads that have some sense of amnesia about this time because it seems to be the most worrisome time for people to, is the baby going to be all right? And there's so much more now that you, as a high-risk obstetrician, perinatal specialist, can do to kind of predict outcomes with imaging, and I'm always fascinated in my pediatric surgical role about the kind of advanced information we get if there is a baby that has a problem that surgery will need. But tell me a little bit more, Dr. Lauring, about have you seen babies with COVID that have that you knew that the moms had it, or maybe that you didn't know that the moms had it?
Yeah, there's a few case reports out there. We haven't seen anyone at UMass yet, but there are some cases out there where women have COVID, and when the baby is born, the baby tests positive for COVID. So far, almost none of those babies have been sick. It seems like a very rare event. Families are more likely to pass it to the baby after the baby is born, just in routine newborn care. But it does seem possible. We don't think it causes those kind of structural problems, like you're talking about, those things that we find on ultrasound. I think a good example is the Zika virus, right? That was a virus that came out of nowhere and caused serious harm to babies. We're not seeing that yet. We have some concerns that it affects the way babies grow, because it probably attacks the placenta in some way. But so far, it's looking like it doesn't seem to harm the fetus and newborn too much.
Well, that's really good news, because I mean, I know that there have been many anecdotal reports about birth rates going up this year. Is that true?
We haven't seen it yet in Central Mass. Our birth rates are actually slightly down or stable. But yeah, there are lots of rumors that the delivery rates are going to go up.
Yeah. So, if you're seeing a young woman in your office that tells you that they're pregnant, or you've told them that they're pregnant, and they said, I had COVID 3 months ago, are you advising them to do anything different or special?
We're not. So for women who had COVID in the past, we're not saying anything needs to be done differently. We haven't really encountered those long COVID syndromes in pregnancy too much yet, or the heart complications. Those people I'd have a little bit more caution about, but I think they don't feel well enough to attempt a pregnancy often. Women who are getting COVID early in pregnancy, right now, we don't really have a lot to say. We're maybe watching them a little more closely, doing a couple extra ultrasounds, make sure growth is appropriate. But we don't have any firm recommendations yet from anybody that anything extra needs to happen. I don't think people should feel, if they have COVID and they recover and are feeling well, I don't think they should feel they have to delay their pregnancy any further.
Okay. And the other corollary of that is if a young woman is pregnant and is expecting in 2-3 months or whatever, you're not telling them to do anything like isolation more so than any other person would.
Right,
They're following the 3 Ws and doing all those things.
Yeah, we're not. So initially we were recommending people to isolate about 2 weeks before delivery to avoid having COVID at the time of their delivery. But you can imagine pulling every pregnant woman out of work is nearly impossible. And so we've loosened up on that and said take the best precautions you can, masks like we were wearing earlier, hand washing, and social distancing, and being smart about who you're seeing outside of your bubble, and really trying to avoid anyone else who might not be as safe as you are.
Great. So, for this year of COVID, for 9 months out of it, we were playing defense, and we tried our best as a medical community to provide the right information for our populace. And here in central Massachusetts, I think our citizens have been tremendously compliant with, the adherence to the right kind of distancing and the hand washing and the wet mask wearing. We really haven't had the same kind of resistance to those kind of premises that other communities have had. Then all of a sudden, starting really end of December, the good news comes out that there's a vaccination round the corner. And sure enough, here in Worcester, January 11th, we started up at the Worcester Senior Center a vaccination program for the phase 1 people. That was the first responders, and then the forward-facing like home health aides and different kinds of healthcare workers. And many of them were pregnant. And they had, all of them came to the senior center, and we were there being asked, should I do this? Should I do this? So what would your answer have been?
Yeah, so my answer is slowly becoming more strong, but it's been a lot of I think so. unfortunately, pregnant women were not included in those initial trials when I think a lot of women would have volunteered. People wanted that vaccine. And so we started with this shared decision-making model saying we don't have any data, we have no reason to suspect any harm, and what's your risk? So healthcare workers did take the vaccine because they were very high risk to get the disease, and understood that the data was not there. There are 30,000 pregnant women or more than that now in the CDC monitoring program. And we actually got our first wave of data at the most recent CDC advisory panel. And it's showing so far there's no change in miscarriage rates, no change in preterm birth rates. It seems like it is as safe as we all thought it is. And so I've become more emphatic in saying it's probably safe. We've got good data now that says it's probably safe. So I do share decision making with my patients. So many of my colleagues took it during their pregnancy when we were offered it in early January, December and January actually. And I'm so proud of everyone that did to get us that information to share with my patients that this is probably the right thing to do because you could be sicker with COVID. So the vaccine has been a great thing. So
is there a time in pregnancy that it's better to get vaccinated than others?
It's a very common question. We don't know yet because right now we don't have any evidence that increases the risk of miscarriage, so we can have it in the first trimester. There is some evidence that it does pass the antibodies through the placenta to the baby. What we don't know is does that actually protect the baby or how long that is. So at some point we may shift to giving it in the third trimester like we give other vaccines so that the baby's protected when they're born. But right now we're sort of we don't have a trimester specific recommendation, but getting it during pregnancy is totally acceptable or right afterwards if for some reason you choose not to.
And this may be a tough question to answer because I certainly don't know the answer. I mean, I don't know if it's known, but is there a difference between RNA kind of based vaccines and DNA based vaccines, like the difference between Johnson & Johnson and Moderna and Pfizer?
As far as pregnancy goes, no. There's a lot of thought about that. So the mRNA vaccines we believe to be safe in pregnancy. There's a lot less data about them in pregnancy, but it doesn't affect your DNA, so it's not affecting the baby's DNA, so it's safe. The adenovirus, there was a little concern that the adenovirus was caught as infection, so people were saying maybe not that in pregnancy. But it uses the same technology as all our other vaccines, so it is probably safe. We haven't really said either one is better at the moment.
Yeah.
But once we get Johnson & Johnson into more pregnant women, we'll have more information.
Yeah. And so how are these women being followed? Is there like an enrollment process going on for trials and things?
There are. Pfizer and Moderna, I believe, are trialing in pregnant women, and then for everyone who gets the vaccine, you get offered to enter the VSafe CDC monitoring program, and it asks you, are you pregnant? And so people are clicking the are you pregnant yes, and then getting contacted, and they're volunteering their information to the CDC to share with us. But there's a lot of post-monitoring going on in pregnancy.
Yeah. So on a scale of 1 to 10, would you say that pregnant moms have been calm about this situation, or has this really been like the kind of thing that you spend an inordinate amount of time calming?
I would say I spend a lot of time talking to people about it. But I also think they're not as freaked out as I thought they would be, right? I think we as healthcare providers were just panicked about this, and patients were like, it is what it is. But in my high-risk practice where we have real medical complications and real issues to talk about, patients just wanted to talk about COVID for months and months. And still it comes up. A lot of it is about what's the experience going to be like, right? The birth experience has fundamentally changed. So I spend a lot of time reassuring people, you will have support, you will have family to visit you. Who's going to visit you after the baby's born? Probably nobody, and we should prepare for that. And so it's a lot of the emotional part of it. The virus, I think they're a little less scared about at this stage. We've got a lot more information.
Yeah. So, you're obviously an assistant professor in the med school, and it seems like the interest in OBGYN is really, I think, increased just over the years that I've been involved with UMass Med, that I've seen so many people understand that the specialty has a lot of the qualities that people like in primary care, and yet you're also being very activist. You can do operations, you can do procedures, you can do public health. There's so many
Yeah.
things. What attracted you to OBGYN?
For me, it was that combination of family medicine, primary care, and surgery. I wanted to see people over long periods of time. I love making relationships with people, but I didn't want to be in an office all day long. Labor and delivery is this incredibly fast-paced place. It's like being in the ER. You never know what's coming next. Some disaster could roll in, and I loved that energy. But I love that I get to spend 10 months out of somebody's life in this really meaningful experience with them, and learn all about them and their family and be a part of that experience.
Yeah. It's an amazing bond. I'm sure that people have told you, you saved my life, you saved my baby's life, you're the most important person in my life, and then suddenly it kind of goes away a little bit, but they never forget that. They never forget that, and that's what's been so impressive to me, mentoring students when they come back from one of the rotations, and I think our department does a wonderful job with, squiring the students and making them understand what a great OB department we have. But I wonder in the setting now where so much of the focus of medicine is to try to identify and undo disparities, if that's changed your practice at all.
Hugely. I think obstetrics has shifted its focus to disparities significantly. We know there are maternal health disparities. We know Black women are more likely to die in childbirth. It's been all over the media for years, and we've all been sitting back going, okay, someone tell us how to fix it. And no one has been able to tell us. And so we've been doing a lot of work, especially in our practice at UMass. We have an anti-racism task force. We're looking for ways to change that. I have worked as part of our quality office trying to standardize things, because one of the ways you can improve health outcomes is to standardize your response to emergency so everyone gets the same treatment. We haven't changed our clinic structure yet, but I try to make sure I pay attention to all those other things, all the social factors and social determinants of health, make sure social work is involved. We're hoping to find a way to get into the communities and reach people before they get to us, and get access to care and help people with those barriers that we see. We're much more aware of all of those things now, which allows us to try to counteract them. We had a meeting just today about a patient whose care wasn't optimal, and there was a lot of talk about did her race and ethnicity play any role in her care, and getting people to have that frank discussion is such the first step in this. We are hoping to make a dent with all of these programs that we have.
Yeah, I'm sure you're aware, and you may already be involved in, we've had a Worcester Healthy Babies Collaborative, which used to be called the Infant Mortality Collaborative for many, many years now. And one of the, I think, unique things that we've actually taken a piece of now to try to reach the part of the population that is hesitant about getting the vaccine was we had a program to work with Ghanaian population here in Worcester, which is a significant part of the population here in Worcester. They had a much worse outcome, matched up with other cohorts than others. And we sent out a series of culturally sensitive text messages all through their pregnancy, reminding them about keeping up with their neonatal vitamins and their appointments and and every phase of the pregnancy. And there was a significant diminution in premature births and in stillbirths during that period of time. So now we are coming up with the two federally funded health centers, and also UMass and St. Vincent's are all in agreement and reliant as well that we will be sending out text messages from the primary care docs to the public about the need to do the vaccine, that they can trust in the vaccine, and it's coming from their PCP, so we are hoping it will have a bigger impact. But that was a lot because of the perinatal work that Dr. Shields and some of the other folks in that collaborative have done. If I can ask, you're a Worcester native.
I am.
And growing up, you must have seen the medical center and driving around. What inspired you to go to medicine in general?
Yeah, in general, everyone always asks, like, I don't have any family members in medicine. My family's all engineers. I kind of struck out in the other direction. I don't know. I never had that crystallizing moment that everyone else has. I just felt this pull towards something more. I wanted to help people. I wanted to do more with the world, and kind of started the process on a whim of like, well, maybe I'll go to med school. And I just fell in love with it along the way. And it was absolutely the right decision. Like for me, it was just a calling from a long time ago.
Oh, that's great. That's great. Well, we're really so fortunate to have you. Would you say that there were any overarching mentors or inspirational characters in your training that led you on a certain path?
Oh, definitely. The OB team in Hershey, I'm still really good friends with them. I did my training all in Hershey, Pennsylvania. And I had our chair at the time, John Recke, and Jamie Paulai, who's now the division director there, just showed me who I wanted to be as a doctor. They were everything I was looking for. They were kind to their patients. They were incredibly brilliant. And so every time I do something, I think, like, what would they do? Is this what they would do? And I still talk to them regularly.
Oh, that's great. You know, I think my other hat that I wear at the school is promotion of health and wellness. Mm-hmm. And many of the students, I think it predated COVID times, but the COVID time has been a really tough pull for them because they haven't been able to rotate to other places. They haven't been able to do a lot of hands-on because we've been trying to protect them from COVID. Mm-hmm. So finally, in the last 2 months, we've been able to put together our vaccine corps, and they've been able to really finally feel like they're making a major contribution to the fight against COVID, which I am optimistic we're gonna win. Yeah. But what do you see after this for the specialty of OBGYN and just for the population facing, should I have kids now, or what do you tell people? Is this a too dark a day to think about expanding your family, or?
This is another one I get a lot, the should I wait? I argue no. Yes, we're on that cusp where things are getting better, and I don't think COVID's going to go away completely anytime soon, so delaying for years is out of the question for most people. And we're in a good place right now. We've got great protocols in place. If there is another surge, we handle them really, really well where we are. And right now the numbers are low. So I think now is the time. I think we have to start thinking about our lives in the future, right? If people want to expand their families, they should. They shouldn't hold up because of where we are now. Looking for all the positives in the world is making a big difference. I think we've pivoted how we care for patients in so many ways. Like telehealth has become a big part of our lives, and I think that will continue for a lot of us. I actually like telehealth. There's a lot of visits that are really fun to just do over a video with the kids playing in the background. I think that's a great way for me to talk to patients. And so I think a lot of lessons learned in the pandemic are going to carry forward with how we care about patients going forward.
Yeah. Now, what are the other high-risk kind of challenges that you deal with all the time before COVID too? But Worcester has had a terrible problem with substance use disorder, and we know what that has wreaked havoc with pregnancies. And have you seen a difference in the kind of populations that have been getting pregnant or that have this problem? In addition to the COVID background?
We have. I feel like for this past year, our substance use disorder population has sort of quieted in comparison to other years. I think we've had less active use, and I don't know why that is per se. But we have a great program in the Green Clinic that cares for women who are actively using. So some of it is I've got Catherine Callahan taking care of it for me, and so I see that less. But certainly, especially in the background of COVID, we've seen patients who are obese, people who are older. In the first wave, it was very clear there were almost no white women with COVID. So all of those other issues, all the socio-demographic factors that affect people's health, we could see it in that first wave. And so we see those women having more and more complications of pregnancy as we go forward.
Well, I can see that our clock is winding down, and this has been incredibly informative and I think in many ways uplifting, because it sounds like life is going on.
Yes, it is.
Yeah.
Yes.
So in just the minute or two remaining, do you have any messages you want to just finally nail down for our viewing audience?
Yeah, thank you for having me. I would say, keep washing your hands, keep wearing your mask. Now is not the time to give up on all of us. It's been a really long year, and we want to get through this. And if you're pregnant, get prenatal care, be seen, have a healthy pregnancy. We can make that happen in a good way.
Thank you so much, Dr. Lauring. So, I think this has been very encouraging. We need to continue to be able to have children, and just speaking as a grandpa to be, unless my kids surprise me, I'm very anxious to know that we can still look forward to that in my family too. This program is going to air all through this next month, and I just want to take a moment to say that we're going to have a commemorative service for the city coming up in a few days, and we have lost over 400 lives to COVID, and there have been many, many, many lives that have been affected by the disease and the long-term effects of the disease, and I want to pay tribute to all the families who have been affected. We're going to get through this because we have a wonderful community that listens. So I'm very grateful that you've been listening to our Health Matters show with Dr. Lauring, who has been so informative and just is a great guest. I want to have you back for sure. And we'll say goodbye. Watch us on WCCA TV, channel 192, or on the WDMS.org website. This will be archived there. So thank you very much. Be well.